Hello, everyone. Welcome back to another day of our review session. We are on day 50 out of the 90 days. We are offering the free NCLEX review sessions for the 90 days, and we are also tackling a variety of nursing topics with focus on med-surg for this moment. Now, we are also inviting you to enroll to our program, our NCLEX course at www.stancoastnclexcoaching.com. Please click on that link. You can see it in the description box below. So kindly check on that one so you will know more about our program. And we also upgraded our library with all the on-demand videos, also the animated video series. And we have 200 NGN test questions plus 3,000 NCLEX style questions along with the resources that we have for your individual study. Now, again, please don't forget to like and subscribe this channel and also like this video in order to help us out and also to share with your friends who are reviewing for the NCLEX. Now, for additional details, kindly click the link below. All right, we have that in our description box. And we also value your feedback. If you have any questions, kindly post them. And we also welcome your thoughts, your comments. So if you could put them in the comment section as well, we would appreciate that. All right, so we have some messages here. I will answer those messages in a minute. Okay, so for those who just came into the classroom, welcome back. If you're a regular attendee, we thank you for your regular attendance. Of course, I hope that you are learning from all the series that we have been lecturing. And for the newcomers, again, welcome. And we are inviting you to enroll to our NCLEX program. Now, today, we will be tackling on this topic about the Myasthenia Gravis. All right, so what is this disorder? Well, this is a problem in the central nervous system. It is going to affect the body, especially those receptors that are what we call as the nicotinic acetylcholine receptors. And the myasthenia gravis in itself is an autoimmune disorder wherein the body is going to mistakenly target. It will produce the antibodies against the nicotinic acetylcholine receptors, which are all located in the neuromuscular junction. Now, the attack is going to diminish the effectiveness of the acetylcholine in stimulating the muscle contraction, and it will also lead to a much more pronounced muscle fatigue. So again, guys, in the myasthenia gravis, there is going to be an attack in the nicotinic acetylcholine receptors. Turn up your volume a little bit. Not quite sure what's going on. I can actually hear myself even with my monitor with my iPad. Let me take a quick look. All right, moving my microphone a little bit closer, but it's right on my face. Okay. Now again, the hallmark in the disease is basically the weakening of the muscles. And the reason about the weakening, it's because of the autoimmune disorder, which actually is going to produce the antibodies, and it again will attack the acetylcholine receptors in the neuromuscular junction, or we call as the NMJ. Now, with that attack, it can diminish the effectiveness of the neurotransmitter acetylcholine. Supposedly, it's going to stimulate the contraction, right? But now the person will end up with much more pronounced muscle fatigue. Can you hear me better this time? I hope that you can hear my voice clear. All right. Now, let's take a look here into the diagram I'm presenting right now. So what is this basically? This is a depiction of how the signals are being transmitted. Of course, we have our acetylcholine, which is the neurotransmitter, and this is needed in the normal function. So how will the muscle work involving the acetylcholine? As we know that this is a very important neurotransmitter, the nerve cells actually will release that chemical called acetylcholine into the gap, which is the synapse, and this is between the nerve and the muscle cells. And here there's what we call as receptor binding, wherein the acetylcholine will bind to the specific receptors. Okay, so look at this right here on this first box. You have the acetylcholine receptors right here at the bottom part of the picture, and then the neurotransmitter will bind to those. Once this process is going on, when there is binding of the acetylcholine into those receptors in the muscle cell surface, this will now allow the sodium ions to get into the also the synapse, and it can now cause the muscle contraction. It will allow the sodium ions to enter the muscle cells. All right, please take note of that. Once the acetylcholine binds into the receptors, it will now allow those sodium ions to enter into the muscle cells. Now, the influx of those ions will now create that electrical signal that will cause the muscle to contract. All right. Now let's talk about the alteration in the muscle function if there is myasthenia gravis. So take a look here in the picture. With an autoimmune disorder, then it can cause the formation of the autoantibodies, right? The antibodies will now create the antibodies will now be created and will attack the acetylcholine receptors. So if you're looking into these red colored strands attaching into the receptors, they are now going to be degraded. And so once they are attaching, if the antibodies are now attacking those receptors, this will now block the acetylcholine from binding to it. Now remember that the acetylcholine and the receptor binding will help with the influx of the sodium, right? Well, that's no longer as effective as before. There is no what we call as a reduction in the sodium influx. With fewer functional receptors, there will be much lesser sodium to enter the muscle cells when the acetylcholine is released. Again, once the antibodies attack those receptors, there is now a reduction in the binding of the acetylcholine into the receptors, and it will also decrease the influx of the sodium entry into the muscle cells. Now, what do you expect with the muscle function? Because of that reduction in the influx, there is going to be much lesser electrical signal. It will be weaker this time, and the patient's contraction in the muscle will be quite reduced. All right. So I hope that you're able to understand really the mechanism of the acetylcholine and also the receptors and the involvement of the sodium in the normal physiology and the myasthenia gravis as well. Now let's move forward here. The myasthenia gravis can also be characterized with muscle fatigue. This is predominant muscle fatigue, and with those muscles that are being used repeatedly. And so those muscles, they're actually frequently used, such as those controlling eye movements, the eyelids. So those are muscles that can be repeatedly used. So these are going to be commonly affected. And as you see in a patient with the myasthenia gravis, they're going to end up with a ptosis. There is going to be drooping of the eyelids because they are susceptible to the fatigue. Now, let's talk about the incidence of the myasthenia gravis. This is a condition that will be more prevalent in women than men, And as far as the incidence in women, usually it happens between the ages 20 to 30 years old. For men, it can happen around the years 50 to 70 years. So again, this can also affect men, but to a lesser incident. More of the myasthenia gravis cases will be targeted more on women. Now, let's talk about the assessment findings here. So you see right now that our assessment finding will primarily have the diplopia and ptosis. These are the earliest manifestations of myasthenia gravis. Please take note of that. Again, the diplopia and ptosis are the earliest manifestations of MG. And again, this is caused by the decrease in the influx of sodium caused by the degradation of those acetylcholine receptors. Now, let's talk about the two. Well, as we know, this is going to be really about 50% of all the cases. And initially, about 50% of the patients will manifest the diplopia and also the ptosis. And it will occur in about 90% of the patients over the entire disease process. Now, let's talk about the other manifestations here. Let's talk about the extreme muscle weakness. So what is this? Well, basically, again, reminding you that it's caused by the immune system attacking the acetylcholine receptors in the NMJ, the neuromuscular junction. So it again will reduce the acetylcholine's effectiveness in those junctions, and it can reduce the influx of the sodium ions to enter into the muscles. And again, it can lead to the significant weakness. The patient will end up with fatigability. Now, when you're going to ask the patient to smile, when you're gonna let them do that, they will have a lack of the muscle control. They have that. They have this mask-like appearance because they don't have a lot of control in their muscles, especially the face. So please take note of that mask-like appearance. Now let's move forward here with the actually, yeah, that's quite similar here. Facial muscle weakness is common, and again, this will lead to that mask-like appearance because they have poor control onto those muscles. And we also have the dysarthria. This is difficulty in speaking. This is the result of the weakening of the muscles in the larynx. Okay? Weakening of the muscles in the larynx. Larynx. Okay? That's going to cause the dysarthria. Now, also the dysphagia, which is difficulty of swallowing. This can result from the weakening of the muscles in the throat area, the pharynx. Okay? So take note of the changes, dysarthria and dysphagia. And along with that, guys, there will be weakness in the proximal limb. So this will basically affect those muscles in the core. Core muscles. Those muscles that are closer to the body. And this will also involve the extension of the weakness into the distal part of the body, like the muscles of the hands. And it can also affect the eye muscles, facial muscles, the bulbar muscles, and also the other distal part of the body, including the muscles of the hand. Okay, so here, the weakness will progress in about 13 months. In most cases, the progression of the weakness will be around this time, 13 months of progressive weakening in these muscles. Now, these are not quite as life-threatening compared to the next one, which is basically the respiratory muscle weakness. If this can affect the person's respiratory muscles, this will now compromise the breathing and also the oxygenation into the body. And of course, this can lead to the airway patency as well. This is life-threatening. Our patient will require intubation and possibly mechanical ventilation. Now, I really want you to recall, especially with the assessment here, how are you going to assess these manifestations if you are going to base it on the cranial nerves? And I hope that you still recall the cranial nerves. Now, let's talk about the cranial nerve number 3. Do you remember that one? This is one of the cranial nerves that will be affected by myasthenia gravis. This is what we call as the oculomotor. All right. So basically, this cranial nerve will control the eye movements, as you can recall, right? It can control the eye movements. It can allow the person to raise the eyelid, the levator palpebra, and it can also direct the eyeball, superior rectus, inferior rectus, the medial rectus. And here with the oculomotor testing, what are you going to do here? You can do the pupillary test, reaction to light. You can also check for the eye movements, having them look up or downward or the medial gaze. And you can ask the patient with a myasthenia gravis, ask the patient to look up for about 30 seconds. Okay? And what you're going to see here in this patient is that drooping of the eyelids. We call this as ptosis. So again, you're going to check the patient at least for 30 seconds, have them look up. But with the ptosis, they will not really be able to maintain that looking upwards because of the droopy eyelids. Okay. Please take note of that. Another testing is to check for the double vision. That's part of your oculomotor testing. Now, let's talk about another cranial nerve here regarding the cranial nerve number 7. What is the 7th cranial nerve? Do you remember that? This is the facial nerve, right? Okay. And this is also affected in myasthenia gravis. Remember that they have no control into their facial muscles. There's like mask-like appearance. So you're going to test this by asking the patient to raise their brows, maybe close their eyes tight, have them smile, showing their teeth, or have them puff their cheeks. So, test those facial movements. Raising eyebrows. What else? Have them close their eyes tightly. And also have them make that smile, showing their teeth. And also have them puff out their cheeks. Puffing of cheeks. If they cannot really perform these instructions that you've given to them, then they have this problem. It is common in myasthenia gravis. They will not be able to really do a whole lot of those procedures or steps that you are asking them. There is a lack of control in the facial movement. Again, this is on facial number 7, facial nerve. So there will be what? Paralysis of the facial muscles that can cause facial asymmetry. It will not be balanced. They will have difficulty in closing their eyes. They cannot really close their lids tightly. And they will have the drooping of the corners of the mouth because of the muscle weakness. So let me write those down for you. Again, there is going to be asymmetry of the face, facial asymmetry, unable to close eyelids tightly, and what else? They will have droopy corners of the mouth, drooping of facial muscle. I'll just put it like that. All right. So that's about cranial nerve number 7. Let's talk about another cranial nerve. What do you think would be the other cranial nerves involved in the Myasthenia Gravis? What do you think? Well, we are going to have to look for that cranial nerve number 9. What is that cranial nerve number 9? Hey, what's going on with my pen? It's changing to a yellow. Okay, cranial nerve number 9, which is what? The glossopharyngeal nerve. And how are you going to test the patient with this cranial nerve? Now, as we know, that the glossopharyngeal nerve is involved with the swallowing, also the taste sensation at the back of the tongue. But primarily, what we're going to do here is to check for the gag reflex. Gag reflex. As we know that our patient will have the dysphagia, right? So if you are the nurse taking care of this patient, check for their gag reflex. If they're able to swallow safely any liquids, okay? So what you're going to do here is you're going to use the tongue blade. You're going to have to stimulate the back of the throat on each side in order to elicit that gag reflex. If there's absence of the gag reflex, then they're not safe to swallow any fluids or any food items. And what you can do as well to check for the gag reflex is have them swallow their own saliva. Yeah, that's another testing, okay? Have them do that if they can swallow. And you should see the movement of the throat upwards if they're going to do that. And have them clear their throat as well. And they should be safe to do it if there's no problem, right? Now, let's talk about another cranial nerve, which is cranial nerve number 10. CN number 10. I know that you're so good with memorizing with all these cranial nerves, but do you really know how to test them in a patient? This is what we have as the vagus nerve. Now, we know that the vagus nerve can regulate the many functions of the body. It will also help out with the functions of the heart, the lungs, the digestive system. But here, the vagus nerve can also get involved with the swallowing. So what you should be testing here is to ask the patient to say, ah, and you have to observe into the patient's throat to see the movement of the soft palate and uvula. So have them say, ah, and you should see the movement of the soft palate. Okay? And also the uvula. You will see it moving. Now, similar with the cranial nerve number 9, the cranial nerve number 10 also is involved in the swallowing. And if there is a problem with cranial nerve number 10, it can also lead to the dysphagia, right? So what you're going to do here is to elicit that gag reflex as well, okay? So don't forget these specific cranial nerves involved in the Myasthenia Gravis. Do not forget that. We still have one more, guys. Not quite done. Cranial nerve number 12. What is this? This is the hypoglossal. Remember that? This actually will help the movement of the tongue. The tongue is a muscle. So if there is a problem in cranial nerve number 12, yeah, your tongue will not be able to really maneuver, and it will probably lead to choking once the patient will be sipping a little amount of water. It will not facilitate proper swallowing of the fluid if it's somewhat weak or if it's paralytic. All right. So what are you going to do in testing the hypoglossal cranial nerve? Simply, you're going to just have the patient stick out their tongue. So let them do just like that. If they can do it forcibly or maybe push the cheek, have their tongue push their cheek from one side to the other side. And then you're going to have to apply pressure into the cheek, have them push your hand or finger and feel for the force in their tongue. Okay. So what's going to happen here usually if there is a severe form of the myasthenia gravis, there's going to be tongue weakness because of the also atrophy. It can also decrease their swallowing ability. They cannot articulate some words. There will be dysarthria. So take note of cranial nerve number 12, hypoglossal. If this is affected in MG, yeah, the patient will have trouble in swallowing. They cannot articulate. They will really have trouble in swallowing even simple fluids. All right. So I hope that you're retaining these important concepts, especially in the assessment of a patient. You might be asked in the NCLEX, just simple assessment. So let's move forward here with other assessment findings. Well, in a patient with myasthenia gravis, they can progress into what we call as the myasthenic crisis. So what does that mean? Well, they are actually lacking the anticholinesterase, which is basically that enzyme, okay, that would break down, okay, lack of anticholinesterase. So what is going to happen in this patient? Well, as we know, guys, that myasthenic crisis, let's talk first about the causes. What do you think can lead to the myasthenic crisis? It could be caused by respiratory infections. So please take note of that. It can be triggered by respiratory infections. It could be caused by aspiration. So if your patient has been choking with the fluid or the food, yeah, it can lead to the aspiration of those food contents. Or possibly medication changes. There are some medications that can exacerbate the myasthenia. There's the beta blockers and some antibiotics. So let me just put them here. Antibiotics, beta blockers. Specifically aminoglycoside type of antibiotics. Now, what are the manifestations, guys, if the patient will lead into the myasthenic crisis? Well, this is going to be much more severe. They're going to end up with respiratory distress. Respiratory distress, think about the breathing, the circulation because of the inability to control the muscles, right? That will aid in the breathing. There going to be a reduction in their oxygenation as well. And it will cause problem to the blood supply or oxygenation to the other tissues in the body. What else? There's going to be the dysphagia, dysarthria, ptosis, diplopia. We know that they are going to be existent already before a myasthenia can happen. I mean, the myasthenic crisis can happen, but they are going to be much more pronounced. Much more severe around this time. Okay. Now, what else are they going to encounter here? They're going to end up with tachycardia, also anxiety, and there is going to be progressive worsening of the weakness in the extremities and also the proximal muscles. Those muscles that are nearest to the core of the body. So again, it will affect the respiratory muscles. Now, this time, guys, let's talk about the classification. This is very important for you to understand that myasthenia have different levels of severity, and this is a good uh, information for you to really review on, because some of the books are just kind of generalize everything in the myasthenia. As nurses, you need to know the classification so you can understand the severity of the manifestations. And this is going to be, the classification was actually presented. This originated by the Foundation of America, Myasthenia Gravis Foundation of America, and they have split this into 5 main classes according to the manifestations. So let's talk about class 1. What is in class 1? So as we know, guys, that the first manifestations will involve the ptosis, right? The ocular muscles. So this will be manifested as the ocular muscle weakness. And this is also going to involve the closure of the lids, remember? And the rest of the muscles in the body are actually going to be normal. So here in stage 1, this is only involving the eye muscle, okay? And also the closure of those eyelids. Please take note about class 1. Now, talking about class 2, the severity here will involve much more of mild weakness of the other muscles in the body other than the eye muscles. And the ocular muscle weakness here will have some kind of a different level of severity this time, because this is already stage 2, right? And we're going to have to subclassify the class 2 as well. So there are going to be 2 subsets. So the first one is class 2A. Now here, the patient will have much more weakness of the limb, all right, the extremities, or it could be both extremities. It can also affect the pharyngeal muscles or the oropharyngeal muscles. This can really affect the swallowing of our patient to some extent. Now let's talk about class 2B, which is going to involve more of the oropharyngeal. And this time, guys, take note about the involvement of the respiratory muscles in class 2B, plus its effect onto the extremities, the limbs, the axial muscles. It could affect both or just one side. And then we're going to proceed to the next classification, which is class 3. This is going to involve the eye muscles as well, but it is going to be much more moderate weakness. Okay, much worse this time. And also it can affect the other muscles in the body, and there is going to be significant weakness. Now, this is also subclassified as class 3A. So this time, extremities will be much more affected with moderate weakness. The oropharyngeal muscles will be significantly affected this time. The swallowing will be much more difficult around this kind of classification. Now, there is also class 3B, which is the involvement, moderate weakness of the oropharyngeal. Now, there's involvement of the respiratory muscles with moderate weakness, and also affecting the limbs, the extremities, the axial muscles. And let's proceed to class 4. The class 4 will be much more of a severe weakness. Weakness in the ocular muscles and also the other muscles of the body. Much more severe. Okay? Now, let's talk about class 4A, which is a subset. It will now affect severely the axial limbs, or maybe one side of the body or both sides, and also affecting the oropharyngeal muscles, and will really significantly affect more on their swallowing. A lot of choking episodes. The patient will not be able to really control their oral secretions. They would not be able to safely swallow their own saliva. Now let's talk about class 4B. What is this? This is much more of a severe form of weakness, respiratory muscles, and also involvement of the axial and the limbs. Now, we don't stop there. There's much more. This patient will require the use of a feeding tube because of significant swallowing disability. They are going to need enteral tube feeding this time. Now let's move forward here with the class 5, which is the most severe of all classifications. This patient now will require intubation. Okay, could possibly use mechanical ventilation as well. All right, except when there is post-operative management. So yeah, it can vary as well. But again, this person will require intubation in class 5. So again, don't forget those different classifications. This will really guide your treatment plan as well. Now let's talk about the assessment findings. Well, one of those assessment findings in the myasthenia gravis will be the cholinergic crisis. What is this? This is caused by the over-medication of the anticholinesterase, wherein there is now excess acetylcholine because the medication, the anticholinesterase medication, is targeting that enzyme that degrades the acetylcholine. But here, our patient will be on the exact opposite side of the spectrum. They are over-medicated, and so the patient will lead into cholinergic crisis. Okay, exact opposite to the myasthenic crisis. So what is going on in the cholinergic crisis this time? There is now excessive activation of those receptors. Remember about the receptors that I've shown you earlier? With the use of the anticholinesterase medication, the medication will now excessively activate those nicotinic receptors, the acetylcholine receptors in the motor end of the plates. So again, this will now lead to excessive acetylcholine. Now, when this happens, guys, the patient will have depolarization of the muscle fibers, which is going to be confusing because in the myasthenia gravis itself, there is already muscle weakness, right? But here, when the patient is over-medicated with the anticholinesterase, they're also going to manifest the muscle weakness. So this is going to require testing in order to differentiate the manifestation. All right. And again, this can lead to respiratory compromise whenever the patient will be over-medicated with the anticholinesterase agents. Now, what else are you going to see in a patient with the cholinergic crisis? They're going to end up with the abdominal cramps because of the excessive acetylcholine. Excess acetylcholine. So the cramping, excessive muscle activity. There will be increasing bowel sounds. Hyperactive bowel sounds. Now, aside from the cramping of the abdomen, the patient will end up with a nausea, vomiting, diarrhea because of the hypermotility. There is excessive stimulation of the SEH receptors, right? Especially in the gastrointestinal tract. And so the patient here will end up with so much secretions, increasing motility of the GI tract. That's why they're going to have the NVD. Now, what else? The patient will also manifest the blurring of the vision because of the overstimulation of the ACH receptors in the eyes. And then they are going to end up with the blurring of the vision and difficulty focusing. Now, let's take a look into the skin of the patient. There will be pallor. And why there's going to be pallor in the cholinergic crisis? This is caused by the vasodilation. And of course, a decrease in the vascular tone because of the excessive ACH. All right, ACH, excessive acetylcholine. It can cause vasodilation. That's why they're going to end up pallor. And there's also going to be what? Decreased peripheral perfusion. Now let's talk about another finding here in our patient with a cholinergic crisis. All right, please pay attention. We're talking about cholinergic crisis, not myasthenic crisis. So what do you think about the pupils? There will be meiosis, constriction of the pupils. So take a look. Even without shining the light or the pen light to the pupils, you will see that they're already constricted. And again, this is caused by the excessive acetylcholine activity in the pupillary constrictor muscle. Excessive ACH in pupillary constrictor muscle. So it's already constricted, guys, before you could shine that pen light to both pupils. Now, what else? The patient would have facial muscle twitching because of the overstimulation with the excess ACH. There's going to be muscle twitching throughout the face and also the muscles in the body. And this is what we refer to as the fasciculations. Twitching. Fasciculations. Twitching of those muscles. Now, what else are you going to assess in a patient with the cholinergic crisis? They're going to end up with what? Hypotension. Why? As we know that with the excess acetylcholine, it's going to cause the vasodilation, right? So your patient will have a significant drop in the blood pressure, and it can also influence the blood supply to the body organs. Now, what else? The patient can also have increasing secretions in the bronchial tree. They're going to have excessive production of their tears and will have excessive perspiration. Please take note of the following. Bronchial secretions. And remember, guys, this can also lead to aspiration, the tearing, perspiration. Again, this is caused by the increased acetylcholine activity. All right, what else? There's much more. Bronchospasm and wheezing because of increasing stimulation of those soft tissue muscles. The lungs will lead into the bronchospasm. They're going to wheeze. And also the heart rate will drop. So take note of those manifestations. These are life-threatening manifestations. You're going to be worried here about the patient's airway, breathing, and also the circulation. Take note, when the patient goes into a cholinergic crisis, pay attention to the ABCs. Same thing with the myasthenic crisis. You're also going to have to deal with the ABCs. Both ends. You need to deal with the patient's ABCs. All right, don't forget these. These are important concepts in myasthenia. Now let's talk about some medications that may exacerbate the myasthenia gravis. It can cause the crisis. Now we're talking about myasthenia gravis exacerbation. I've mentioned two of those medications. One of those will be the antibiotics. And what are those antibiotics, guys? One is the aminoglycosides. Can you still remember what aminoglycosides are? Are you familiar with these? We have the gentamicin. Gentamicin, also neomycin, or the amikacin. These are common aminoglycosides. And why? They're going to precipitate or exacerbate the MG. We know that the the medications, the aminoglycosides, they can inhibit the acetylcholine release. They inhibit acetylcholine release. And we remember that acetylcholine is a neurotransmitter that is supposed to attach into the receptors, right? Which will allow the sodium to get into the muscle. And so if there is inhibition of the acetylcholine, then what do you expect? There's no good amount of the sodium ions that can enter into the muscles. So again, this can worsen the muscle weakness. Worsens muscle weakness. What else? There's another classification of antibiotics. We have them as the fluoroquinolones. So if you're familiar with ciprofloxacin, or the levofloxacin, the Livaquin, Livaquin, ciprofloxacin. These are your representatives of the fluoroquinolone classification, and this can also have neuromuscular blocking effects. Neuromuscular blocking effects. So when you are the nurse taking care of this patient, if you are doing the medication reconciliation, let's say you are admitting a new patient to the facility, and if they are taking these medications and if they have exacerbation of their myasthenia gravis, you need to communicate right away to the medical provider. Hey, doctor, our patient is actually taking these drugs. Well, yeah, it can exacerbate the myasthenia gravis. So that's your responsibility to report any medication use that can exacerbate the condition. What else? Beta blockers. Those olols, like propranolol, metoprolol, they can also exacerbate the myasthenia manifestations by blocking the beta adrenergic receptors. Blocks beta adrenergic receptors. And when the blocking happens, there's going to be a reduction in the neuromuscular transmission. Those impulses that are supposed to be relayed to the next synapse or neuron, well, with a blockage, this can also increase the muscle weakness. Increases muscle weakness. Now let's talk about other medications. Antiarrhythmics. Yeah. Do you remember the antiarrhythmic concept? I presented to you the SBPC, the sodium channel blocker, the beta blockers, the potassium channel blockers, calcium channel blockers. But here, our antiarrhythmics that are commonly identified to cause exacerbation of the myasthenia gravis are those sodium channel blockers. So what are those medications? Remember about the quinidine, the procainamide, also the lidocaine. Those are our representatives for the antiarrhythmics. I think I have them listed here. We have the quinidine, the procainamide, and the lidocaine. These are known sodium channel blockers that can also exacerbate the myasthenia gravis. Again, they can decrease or they can interfere, decrease transmission of nerve impulses. It can cause weakness into our patients who has pre-existing myasthenia gravis. Now, same thing with the lidocaine. Remember that the lidocaine can affect the sodium channels? Yeah, it can also disrupt the transmission. It can exacerbate the myasthenia gravis. So I hope that you're learning from all these medications. And this is not just for you to memorize. It's for you to apply this in a situation wherein a patient might be admitted for an exacerbation of myasthenia gravis. Or let's say if you're a nurse taking care of this patient and there might be some new medication orders and could have been missed by the medical provider, maybe they're going to order something that probably they didn't really think about, which can really complicate in the treatment of the myasthenia gravis. You got to make sure that you're going to question that order if in case that it's added into the treatment for a patient with a pre-existing myasthenia gravis. That is your role, guys. Identify those risks. We need to reduce those incidences that we can administer those medications that are not supposed to be given. Now, let's talk about the diagnostic test of the myasthenia gravis. All right, we'll talk about the acetylcholine receptor antibody test. Remember about the pathophysiology earlier that I've shown you regarding the development of the autoantibodies in an autoimmune disorder that can cause the MG. Remember about that? And so the acetylcholine receptor antibody test is going to diagnose this patient. It will be the most specific test in finally diagnosing this patient with an MG. Okay? All right? That is our acetylcholine receptor antibody test. It is the most specific testing. Now, another is the electrophysiologic test. Now, why are these tests going to be very important? Well, as we are going to talk about these two common tests. One is the repetitive nerve stimulation test. Repetitive nerve stimulation, or what we call as the RNS. Okay, so what is this? This is going to check the patient. It will repeatedly stimulate a nerve at a slow rate. Again, the testing will involve repeated stimulation of a nerve. Stimulation. But this is going to be done in a slow rate. If autoimmune destroys acetylcholine receptor, which does not allow to go to the muscle, how will being exist under cholinergic crisis? Well, remember about the cholinergic crisis. This is only going to happen if there is the over medication. We are treating them with the anticholinesterase. This is the exact opposite. Okay, remember about the anticholinesterase. This is a medication that will target that enzyme that will degrade the acetylcholine. So basically, this time, there is now an excess of acetylcholine. All right? So I hope that you're understanding the concept. It is the exact opposite. The anticholinesterase is treating the patient, but whenever it's over medication, the patient will go onto the other spectrum. Okay? Exactly different. All right, let's talk about the repetitive nerve stimulation. What does it measure? Well, it can measure about a decrease, 10% decrease. It can detect 10% decrease in the nerve response between the first and the fifth stimulation. So this is going to be a very valuable testing that the patient really will have some kind of exhaustion. It will no longer be able to respond to the stimulus. Okay, again, 10% or even more than 10% reduction in its response to the stimulus. Okay, so RNS, don't forget about that. We also have the single fiber electromyography. These are actually much more of fancier names that you won't see in the regular textbooks. especially in nursing textbooks. I've gathered more information into the NIH. The single fiber electromyography is much more sensitive, very sensitive testing. It can record the signals from the individual muscle fibers, and it will also look at this at the time difference, the jittering between the signals from the two fibers controlled by the same nerve. And the testing can also measure the jitter increase because of the problems in the neuromuscular junction communication. And here, the SFEMG, this is going to really measure the jitter increase. Measures jitter increase because of the problems of the neuromuscular communication. So again, this will be very effective tools in the diagnosis of the MG. So, but take note about the acetylcholine receptor antibody test. This is the most specific. The other two, the electrophysiologic test, this will be used to investigate further the severity of the weakness or the severity of the myasthenia gravis affecting the core muscles or maybe the proximal limbs. Now, there's also chest CT scan, and this is going to be used to rule out the presence of thymoma, which is basically a mass. All right, so this is going to detect the presence of a tumor in the thymus gland. All right, so according to the statistics, there's only about 10 to 15% of MG patients. 10 to 15% of myasthenia gravis patients that have a thymoma. All right. Now, another diagnostic test here is the tensilon or the hydrophonium testing. So what is this? Well, it involves the administration of the hydrophonium, right? And this is an anticholinesterase drug. Anticholinesterase medication. And when you are going to administer this drug, or let's say the provider will be administering this medication, there is going to be a temporary relief of the muscle weakness. Temporary relief of muscle weakness. Or let's just put it that way. There's going to be improvement of muscle strength. Muscle strength. Arrow up. Muscle strength. Again, this is going to cause temporary increase in the muscle strength. However, guys, this testing has according to the statistics about the use of the hydrophonium, it has a high rate of false positives. High rate of false positive. So it's not really the perfect test for this patient, especially in differentiating the myasthenic or the cholinergic crisis. But as we know in the nursing books or maybe in the NCLEX, this is regarded as a very important tool or diagnostic test to differentiate between the myasthenic and the cholinergic crisis. All right. But again, it has a high rate of false positive results. Just throwing it out there. Okay. Now, what is involved in the hydrophonium testing or the tensilon test? How is this going to be done? The procedure of tensilon testing. How is this done? Well, this is going to involve the use of the medication itself, which is the hydrophonium, right? So this is going to be given as either IM or IV. Okay. And for the diagnosis, for the diagnostic purposes, the dose that will be given will be around 8 to 10 milligrams. And if you are giving this IV, it will be slow IV push for about 1 to 2 minutes. Again, when you are delivering the edrophonium, you're going to have to deliver it. If the specific order is IV, then you're going to have to give it slow push 1 to 2 minutes. Now, the next step here, after you administered the drug, you're going to need to monitor for the patient. What will be the monitoring entail here? Well, you're going to note for the muscle strength improvement. Take note about muscle strength. If there is improvement of the muscle strength, or let's say there is now lessening or much lesser problem in their swallowing, or if they can talk better, then that is a good sign that this is a patient really has a myasthenia gravis, right? Again, muscle strength is improved and the patient's speech is clearer speech, less dysarthria, if it's effective. However, though, you're going to have to watch for adverse reactions. What are the adverse reactions that you need to take note in this patient? The medication can cause bradycardia, decreased heart rate. It can also lead to bronchospasm. So you need to keep an eye on your patient also for excessive salivation. So these are things that you need to watch for after you've given the medication, the edrophonium chloride. These are adverse reactions: bradycardia, bronchospasm, excessive salivation. So before you're going to start, or before you involve yourself in testing this patient, or let's say if you are assisting the medical provider in giving the drug, make sure that you have a emergency equipment available, okay? Those airway equipment, make sure you have them available, standby, just in case our patient will go into a bronchospastic episode. This is life-threatening. Again, there's trouble with the airway patency. Now, let's talk about the duration about the edrophonium test. How long will this drug going to affect the patient? It will last for about 5 to 10 minutes. So all throughout that time frame, you need to monitor this patient for all those adverse reactions, and you need to respond accordingly to what reaction that they might display. So you got to be ready with all those adverse effects. Now, of course, you're going to have to document, right? That's part of the care in order that we can legally indicate there what the patient's manifestations are or what adverse reactions that they might have as well. Now, let's talk about the treatment this time. What will be the treatment for the patient with a myasthenia gravis? Again, don't forget, myasthenia gravis is the lack of acetylcholine, right? And also the lack of the sodium influx. Please don't forget this into the muscles. If you know the core concept about the problem, you will not be confused, right? So don't forget myasthenia gravis. There is decreased acetylcholine because of the antibodies attacking those the receptors as well. Not just about the receptors, but it can also decrease the acetylcholine activity, I should say. All right. Sodium influx is also reduced, and this is going to be one of the reasons why there is muscle weakness. So how are we going to treat this patient with myasthenia gravis? We're going to have to administer them as prescribed the anticholinesterase inhibitor. And the pyridostigmine is one of those commonly used anticholinesterase drugs they're going to inhibit, it will stop the breakdown of acetylcholine. Stops breakdown of acetylcholine. Don't forget that. And so what's going to happen after the patient is going to be treated? There's going to be increased concentration of acetylcholine in the NMJ. Since we are medicating them with the anticholinesterase, the acetylcholine will be increased in the NMJ, neuromuscular junction. Okay? Guys, please take note that the anticholinesterase only provides symptomatic treatment. It doesn't cure. Not a cure. It will only treat the symptoms. No cure for MG. Okay? Now let's talk about, maybe that's false. There's more actually, so hang tight. Another treatment is the thymectomy. What is thymectomy? This is the surgical removal of the thymus gland, especially if there was a thymoma, right? If there was that thymoma, and not all of the myasthenia gravis have the thymoma, as I've said earlier. So only for those patients that have thymoma, they're going to require, or they're going to need the surgical removal of the thymus gland. And it can also lead to much more significant symptom improvement. There will be remission of the symptoms, right? Again, before I'm going to proceed, I'm inviting you to enroll to our NCLEX course at our website at www.stancoastnclexcoaching.com, and also check the description box below. We have the link there, so you can check out the pricing and everything and the services that we have. All right, let's move forward. Another therapy or treatment that can be ordered by our medical provider will be with the use of the immunosuppressants. Immunosuppressants. Why are they going to be useful? Well, first, we're going to have to identify what these immunosuppressants are. And one of those are the corticosteroids. So if the patient will not be responsive to the anticholinesterase inhibitors, the medical provider will start including the corticosteroids, right? So indicated if patient does not respond to anticholinesterase. So corticosteroids, they can work as immunosuppressants. It can lead to a much less responsive immune system. Remember that this is caused by an autoimmune problem. So the corticosteroids will suppress the activity of the immune system. Suppresses the immune system. And of course, this can also reduce the production of the antibodies. Remember that. The autoimmune problem can involve the production of autoantibodies. So, decrease in autoantibodies. So that's why the corticosteroids will be part of the treatment plan if the patient doesn't respond to the anticholinesterase. However, as we know, if the patient will be using the corticosteroids, remember about the complications. I'm sure that you have already known this, but don't forget to utilize those concepts, especially if you're going to be asked about the risks, the possible complications of the patient taking the corticosteroids. Remember about those? Hyperglycemia, Cushing's syndrome. Yeah? Right. Hyperglycemia. There's also increased risk for infections. Remember about that. High blood pressure, weight gain because of the retention, more adipose tissue. Right. So don't forget about those complications when the patient is treated with the corticosteroids. Now, what else? Let's talk about another immunosuppressant, which is also commonly used, azathioprine. Are you familiar with this? Azathioprine? This is going to be used as well to suppress the immune system. That's why it's called immunosuppressant, to suppress the immune system in order to decrease the production of the antibodies. But here, when we're talking about the azathioprine, this is much more specific. Let me just get rid of this. The azathioprine is going to inhibit the proliferation of the T and the B lymphocytes. Inhibits T and B lymphocytes. So remember that these are going to be responsible in the production of the antibodies. Yeah, they are the producer. So let's scale the producer. No, just kidding. They are known producers of antibodies. So if we are giving them the azathioprine, this will subsequently will stop the production, or let's say suppression in the production of those antibodies, because it will specifically target the T and the B lymphocytes. It will also reduce the active immune cells in the body. So if there is decreased activity by the antibodies, or let's say decreased immune response, well, what do you expect? The patient with MG will have improvement in muscle strength. That would be our therapeutic effect. Improvement of muscle strength. Now, this is going to be used as a long-term treatment for the patient with the myasthenia gravis that are not responsive to the anticholinesterase. But take note, guys, since this is also a immunosuppressant, don't forget that the medication can also have several adverse effects, and we're going to talk about that right now. So what are the adverse effects of the azathioprine? There are several. One of the adverse effects will be the bone marrow suppression. Now, you know about the bone marrow suppression, right? And what it can do to the blood counts. Yeah. So there is going to be pancytopenia. Whoops. All the blood cell counts will be severely decreased. Pancytopenia. I'm talking about the white blood cells, the red blood cells, and the platelets. So the blood counts again will be suppressed. Our patient will be prone to developing opportunistic infections. They're going to be prone to the bleeding because of the reduced platelet count, and they're going to develop anemia as well because of the decreased RBC production. It's targeting the bone marrow, pancytopenia. All right. Now, aside from the bone marrow suppression, take note that it can also lead to GI adverse effects. What are these adverse effects involving the GI tract? Well, you have the regular NV, nausea, vomiting. There's also diarrhea, and there's also abdominal discomfort. So these are known adverse effects. What else? There's another one. Another critical adverse effect. Liver toxicity. We are still talking about azathioprine. So before you're going to initiate or start the patient on the azathioprine, what do you need to do as a nurse? Make sure that you are assessing the patient's liver function. So there should be baseline LFT. because the azathioprine itself can cause enzyme or liver enzyme abnormalities. It can cause severe liver toxicity. What else, guys? There's more. We're talking about immunosuppressant medications. Yeah, it will give you benefits, but it can also harm the patient. So make sure that you are screening our patient for any of pre-existing conditions. So aside from liver toxicity, what else would be the known adverse effect? We have number 4, pancreatitis. Pancreatitis, inflammation of the pancreas. Alrighty. This is rare, but a serious side effect. I'm just including it here. Another would be skin reactions. So what you need to do here is to thoroughly assess the integumentary system of a patient. The common ones are those rashes, itching. Now, as we know that the azathioprine is also an immunosuppressant, yeah, another drawback with this medication is the occurrence of malignancy, occurrence of new cancer. There will be new cancers like, let's say, lymphoma. This is the highest in the statistics, especially when a patient takes immunosuppressant. Lymphoma, skin cancer, when the patient is using the azathioprine for long term. Okay, so these are the following. We have bone marrow suppression, GI, adverse effect, liver, toxicity, pancreatitis, skin reactions, malignancy. Now, you probably would know as well that the cyclosporin is another immunosuppressant here, which is actually listed. It's getting longer, but I really want to share this with you because who knows what comes out in the exam. Cyclosporin is also an immunosuppressant. It can also inhibit the T cells. It will be used in severe cases of MG. Again, it will be used in the severe case of MG, Myasthenia Gravis. Now let's talk about the cyclosporin. Well, I would not just share the dosing here. It's probably not going to be asked. But again, since it is immunosuppressant, we need to monitor our patient for the pancytopenia as well. Their risk of developing infections, anemia, bleeding, and another is, let me just put it right here. Our cyclosporin is toxic to the kidneys. Nephrotoxic. So if you are the nurse, before you're going to start giving this medication to the patient, what do you want to do here? Check renal function panel first. Baseline renal function information should be available before we start the therapy because it's known to be nephrotoxic. And of course, after the baseline information, we need to do some follow-up testing for this patient to make sure that our patient is not developing renal failure as well. And so many others. There's hypertension, there's going to be neurological problems, GI issues. There's also increase in the cholesterol, hyperlipidemia. Yeah, that's another one. Hypertension, hyperlipidemia, and the popular gingival hyperplasia. There's so many adverse effects in these medication, guys. So many, trust me. And also increasing hair growth, hypertrichosis, and all, of course, the pancytopenia. Don't forget about that. Now let's talk about another treatment in myasthenia gravis. Another is the plasmapheresis. This is a procedure wherein the patient will have a removal of those antibodies against the acetylcholine. So this plasmapheresis will be indicated for this patient in order to remove the antibodies. Removes antibodies against the acetylcholine receptors from the blood. Remember about the antibodies targeting the acetylcholine receptors? Yeah. So the plasmapheresis will involve the removal of the plasma from the patient's body, of course. It works like a dialysis, but it will be replaced with albumin, or let's say saline. So again, it will remove the circulating antibodies and also the inflammatory mediators. Not just the antibodies, but also inflammatory mediators. Okay. Now, the procedure itself can be done in about 3 to 5 sessions within a span of 5 days. Okay, especially in a patient with a myasthenia crisis. So again, the session here will involve 3 to 5 days of plasmapheresis within a span of like let's say a week. Okay, 3 to 5 sessions. Now, the procedure can also last for several hours, including because the circulation of the blood through the machine will take a lot of time. It will separate the plasma, it will separate the blood cells as well. Then it will be replaced with the albumin before it can get returned to the patient. However, guys, we have adverse effects for the plasmapheresis as well. Adverse effects. What do you think are the adverse effects of the plasmapheresis? Well, if there is no careful maintenance of the aseptic technique, your patient can develop infection. What else? They're going to end up with low blood pressure. Could be allergic reactions. Maybe they're reacting to the albumin or the replacement fluids, and possibly electrolyte imbalances. So these are the adverse effects of the plasmapheresis. Again, infection, hypotension, and also electrolyte imbalances or the allergic reactions. All right. These are known, even though that they are rare, but these are known adverse effects, and that is why our patient would require high monitoring during the procedure. Make sure that we are assessing our patient's overall neurologic status. We're going to have to look into their coagulation profile as well. Make sure that after the procedure, we're going to have to assess the patient for any signs of fluid imbalance, vital signs as well. We're going to have to watch the signs of the other reactions: hypotension, infection, allergic reaction. So another treatment in the another treatment in the myasthenia gravis is the use of the intravenous IG therapy. And this is something that I had experienced several times in the neuro unit. This can require one-on-one patient care. Yeah, while you are administering the medication to the patient, this will require one-to-one care throughout the infusion. This is going to cause some allergic reactions. In some cases, it can lead to anaphylaxis. So the patient will be treated with the IVIG because it can manage the acute exacerbations. Acute exacerbations. And the patient here will really get the benefit of the immunomodulatory effects of the IVIG. It's not fully understood yet why this is going to be effective, but it seems like the IVIG can neutralize the autoantibodies. Okay? What are the effects here? Antibody neutralization. So it will not be as hyperactive anymore if we are going to treat them with the IVIG. What else? It can also stop the development of the complement activation. Decrease complement activation. As we know that in the immune system, remember about the complement system? It is part of the immune system wherein it can be activated by the antibodies, and this can rapidly cause inflammation and tissue damage. And so the IVIG will be effective in really suppressing the effects of the immune system. All right. And this is really going to require frequent blood pressure monitoring, the vital signs. You have to make sure that you have the, what do you call this? The anaphylaxis kit. Make sure that you also will be medicating the patient with antihistamines. And it can vary from one institution to the next. Maybe the doctor will pre-order the antihistamine medications before we start the IVIG, because it's also a high-risk procedure. And it's no fun. You're going to be in the patient's room the whole time talking to them. You're going to have to watch the infusion. It doesn't last for just an hour. In some cases, it can last for a good 6 to 8 hours. It can vary, guys. And it depends into the patient's tolerance to the medication as well. All right. Now, let's talk about the management of respiratory function. So what is this? We are going to schedule the patient with this kind of testing, especially with the vital lung capacity, the FVC. Okay, so remember about that. We need to make sure the patient undergoes this kind of testing in order that we can identify if the patient is going to lead into a much more complicated state, especially in myasthenic crisis. They need intubation. All right, let's talk about the other treatment. What are we going to do if the patient goes into a myasthenic crisis? Well, it is recommended, it is highly advised that when the patient has the manifestations of myasthenic crisis, they need to be admitted and they need to be placed in critical care because of the problems in their airway. They will not be able to control their breathing. They need intubation. So definitely our patient will require that. What else? Our role here would be really to monitor their respiratory status closely. And also we need to get ready with the possible treatments, interventions that can reverse the crisis. Now, another is the use of the interphonium testing. Remember about that. This is a short-acting medication that can therapeutically improve the manifestation. It can differentiate between the myasthenia and the cholinergic crisis. Don't forget about that. Now, when we are going to encounter this patient with the myasthenic crisis, remember that airway is priority. Again, myasthenic crisis, the involvement of the respiratory muscles, they're going to end up with respiratory failure around this time because of the muscle weakness in the respiratory stuff or respiratory system. We need to maintain the patency, make sure that we are monitoring the pulmonary function as well. And plasmapheresis is another treatment for the myasthenia crisis. The exchange, right? The filtration of the antibodies in the bloodstream, and this will be replaced by the albumin. Another is with the use of the IVIG, which is going to modulate the function of the immune system. It will somehow decrease the activity of the immune system. Now, what else? We have the neostigmine, which is the anticholinesterase. That is part of the treatment. Neostigmine. Again, anticholinergic medication discontinuation should be like atropine sulfate, anticholinergic agents. If this is part of the patient's treatment, that needs to be discontinued if they're going to go into the crisis. Now, what else, guys? We're going to have to, actually, before I'm going to go into the complications, part of the treatment here especially is the corticosteroids, which I forgot to put in here. Administration of the corticosteroids. Remember that is very important in reducing the inflammation. It also reduces the immune response. Okay. Now let's talk about the complications of the MG. Part of that would be the aspiration, the respiratory failure, and the complications of their decreased mobility. Now, let's just go through the nursing process right now. Part of our care will be to make sure, assess our patient carefully. Make sure that you're able to identify the severity of their condition. Make sure you do that. How bad is the weakness of the patient? How bad is the fatigue? And you need to adhere to the classification as well, so you will know for sure what needs to be done for this patient. Now, what else? We're going to have to check for the cranial nerve function. Do not forget those 4 or 5 cranial nerves that I mentioned earlier. Make sure that we're going to have to assess for the fatigability, especially motor fatigability, respiratory status, since it can compromise their breathing, and also the patency of the airway, and also the complications of the medication. So assess if they are taking those meds that can exacerbate the myasthenia gravis, like beta blocker, aminoglycosides, fluoroquinolones, and what else? We're going to talk about fall risk assessment. This is important. They are going to be prone to falls because of the limb weakness. So let's not neglect that one. What else? We're going to have to intervene the patient through minimizing their fatigue. We're going to need to conserve their energy. So if they're really exhausted, don't get them moving out of bed. Preserve their energy. We need to plan their activities in the hospital. Make sure that they have adequate rest periods, meal periods, and also we have to prevent the aspiration. Remember that it can cause the dysphagia. This is going to be a common complication, aspiration. Make sure that you're going to put the patient in aspiration precautions. What would you do here? Well, part of the aspiration precaution is to make sure that you're following the prescribed texture of the food items, or let's say the prescription by the nutritionist. What kind of liquids are they supposed to be taking? Is it going to be honey thick or nectar thick? Because they're really prone to choke on these items. So make sure you do that. And when they are eating during the mealtime, and when they are taking any fluids by mouth, what would you do? Make sure that your patient is positioned carefully. They're upright before they swallow anything. Make sure they're sitting upright. During oral intake. What else? We want to make sure that our patient is wide awake when they are taking anything by mouth. Do not place any liquids or solids when the patient is drowsy. No way. Make sure that the patient is alert during this procedure. What else? Make sure that you have available suction equipment as well. That is part of the aspiration precaution. Suction equipment to be used for the excessive salivation. Okay, let's talk about, oh yeah, we have the positioning during meals. Airway suctioning is needed. Communication alternative. Remember about the dysarthria? They will not be able to really pronounce well those words, and this can be misunderstood. And so make sure that they have available whiteboards and stuff so they can write words instead of talking garbage or gibberish. What else? We're going to need to have some speech support. So speech therapy is also important here. And what else? Fall prevention strategies. This is to reduce the incidence of falls. All right. What else we're going to need to do in this patient? We're going to have to educate them. So many stuff to educate in our patient. We're going to have to educate them of what manifestations should be noticed or observed, especially at the home setting. They need to know what manifestations they should report to the medical provider if in case they're going to go into the crisis. Especially if they have infections, right? Infections. This can precipitate the myasthenic crisis. Now, let's talk about medication management. This is very important. We are going to explain and emphasize to them the compliance to the treatment, make sure that they will take the medication on the exact time, especially with the anticholinesterase, mostly taken before meals, and to possibly avoid possible drug interactions. This is very important. Now, another is lifestyle modifications. We need to ensure that they understand that they need to do this in order to avoid any infection, avoid extreme temperatures, avoid infections. What else? Extreme temperatures, and also emotional stress. So those are things that we need to incorporate in our teaching. Lifestyle modification, avoiding these exacerbating situations. Okay. Now, we're going to talk about the use of a medic alert, avoidance of alcohol as well, tonic water. Yeah. What is about alcohol and tonic water? Well, the two can actually interact with the myasthenia gravis medication, and it can now potentially exacerbate the MG manifestation as well. So here are just important measures that we need to incorporate in our education. Now let's go start with our test questions. Number one, when assessing a patient with myasthenia gravis for signs of cholinergic crisis, which of the following should the nurse check? Select all that apply. Is it A, drooping eyelids, ptosis, B, muscle twitching or fasciculation, C, stomach cramps, D, increased heart rate, E, reduced secretions, F, irregular and slow breathing? When assessing a patient with myasthenia gravis for signs of cholinergic crisis, which of the following should the nurse check? Remember that in cholinergic crisis, the manifestations are actually similar to the myasthenic crisis as well. So pick the best answers that you can find here. Is it drooping eyelids? Is it muscle twitching or fasciculations? Or will that be stomach cramping, increased heart rate, E, reduced secretions, or F, irregular and slow breathing? We have Mary answering B, C, E, or it looks like she retracted the answer. So what are those signs of cholinergic crisis? Cholinergic. Let's try to filter these answers. Let's start with letter A, drooping eyelids. Drooping eyelids. Guys, if the patient has the cholinergic crisis, remember about the cholinergic, this is a result to the over-medication, right? Over-medication of anticholinesterase. Too much of the anticholinesterase agents neostigmine, pyridostigmine. Well, it is going to be similar to the myasthenic crisis or myasthenic manifestation. So the patient will also have overstimulation of the muscarinic and nicotinic receptors. Overstimulation can also lead to ptosis. Overstimulation of nicotinic and muscarinic receptors. It's way too much of the anticholinesterase medication. And again, it can impact the neuromuscular junctions. It will also lead to weakness and fatigue. So it, again, will be similar to the myasthenia gravis, right? Weakness and fatigue. Weakness. All right. So that's one. What about letter B? Muscle twitching fasciculation. Yeah, the fasciculations are also going to be one of the answers. They are the involuntary muscle twitches because of the continuous stimulation due to continuous overstimulation. Overstimulation of muscle fibers. What else? What about letter C? Okay, so we are actually including that one. So not all manifestations will be similar. There are some that will be similar with the myasthenia gravis manifestations. So let's take a look of letter C here. What is in letter C? Stomach cramps. While they can possibly occur in the cholinergic crisis, right? Because of the GI motility from the excessive acetylcholine, and also the stimulation of the, what do you call this? The muscarinic and the acetylcholine receptors. But they are not as critical for the immediate assessment. Not as immediate, not as critical, I should say. So, not as critical with the other manifestations. Okay, so let's go back into the question. Which of the following should the nurse check? So it's actually wanting us to identify those manifestations that are critical, that can be seen easily in a patient with cholinergic crisis. And that is why stomach cramps, even though it can be assessed in a patient with a cholinergic crisis, but again, it is asking for a priority assessment. They are not as critical value compared to the others, like the drooping and the fasciculation. They are going to reflect more of the neuromuscular involvement. Okay, now let's take a look into letter D, increased heart rate. Do you think that the person will have increased heart rate? Well, it's not really a typical manifestation in cholinergic crisis, so we are going to remove that as well. Not a manifestation in cholinergic crisis. Now let's talk about reduced secretions. Reduced secretions. In the cholinergic crisis, there is going to be much more of the salivation. Remember about what I said earlier? Reduced is wrong. There is no reduction in the secretion. What you can find in the cholinergic crisis, there is going to be excess salivation, also excess lacrimation or tearing in the eyes. And remember about the bronchial secretions. Yeah. These are, oops, let me write that out better. Bronchial secretions. All righty. So reduction of secretion is wrong. What about irregular and slow breathing? Do you think that it will be one of the manifestations in cholinergic crisis? Yeah, remember about the severe respiratory compromise, the bronchospasm as well. This is going to lead to irregular, slow breathing, and this is a critical sign of cholinergic crisis. Critical sign of cholinergic crisis. All right, remember that. Okay, so our answers here are letter A, letter B, and letter F. We are looking for those priority assessment findings. Okay? All right, we are in a crisis mode here. So look for those signs that are very critical. Let's tackle number 2. How does the nurse determine that plasmapheresis therapy has been effective in a client with refractory myasthenia gravis? Is it A, improved lung function, B, increased leg strength, C, reduction in drooping eyelids, D, clearer vision or reduction in double vision? Let me reread. How does the nurse determine that plasmapheresis therapy has been effective in a client with refractory myasthenia gravis? Is it A, improving lung function, B, increased leg strength, C, reduction in drooping eyelids, D, clearer vision? Take your pick. But while you do that, I'm going to start eliminating some options. We're talking about plasmapheresis. Asking for effective therapy. What are those? Which of the following options will correspond to an effective treatment? I'm seeing C's. Okay. So let's try eliminate letter D if we can. Clearer vision, reduction in double vision. Guys, remember about the plasmapheresis. This is going to be used in a patient that is really going to need much more of immediate treatment. It can remove those antibodies. And so the patient here will have much worse of manifestation, especially respiratory function. Like what I've said earlier, the plasmapheresis will be done in a span of 3 to 5 sessions within a short period in order to remove the antibodies. And the patient here that will be getting the plasmapheresis will have much more of the manifestations. And critical to the manifestations will be on the respiratory function. Okay, I hope that you can still figure that out. Respiratory compromise. So let's start to eliminate letter D, clearer vision. I know if there is an effective therapy, clearer vision is one of those manifestations. If there is a reduction in the blurring, that's good, right? That is a good indication. However, it is less relevant to the immediate and critical goal of the therapy. Less the manifestation itself, the improvement of the symptom is less relevant. It is one of the signs that there is improvement, but less relevant to the immediate need of having the plasmapheresis. Okay. It's okay. It's a good answer, but it's not really the main goal while the plasmapheresis was ordered. It isn't. Let's take a look into letter B, increased leg strength. Do you think that the decrease in the leg strength was the main reason why the plasmapheresis was indicated? I don't think so. The plasmapheresis, though, can improve. It can improve the leg strength, but it is not really the primary measure of the effectiveness of the plasmapheresis. Not the primary measure or indicator of plasmapheresis effectiveness. Okay, so we are left with A and C. What do you think would be the main reason, really, that there is a need to do the plasmapheresis? Is it because of the drooping eyelids, or is it the function in the lungs? We're talking about respiratory compromise, and that is why the patient will be requiring the plasmapheresis. Our answer is letter A. The drooping of the eyelids is just the secondary manifestation that there is an effective plasmapheresis therapy. It is not the main indicator. Our main indicator is improvement in the lung function. Okay, don't forget that. That is the main goal of the plasmapheresis, that there should be improvement of the vital capacity. Alrighty. How do you find this test question, guys? It's quite challenging, right? It is very critical. So take note about the respiratory compromise in this patient. Yeah, let's select letter A. Let's take a look into option number 3. What indicates that a client with myasthenia gravis has a realistic understanding of their condition and its management? Is it A, expecting the disease to be fatal eventually, or is it B, believing the disease will be cured, or C, managing symptoms and maintaining a healthy lifestyle, or is it D, anticipating occasional muscle weakness despite treatment? What would be that? What indicates that a client with myasthenia gravis has a realistic understanding of their condition and its management? So, among the 4, which of the following reflects that the patient understands the disease process? Okay, let's try to eliminate letter A. What is in letter A? Expecting the disease to be fatal eventually. We know that it's serious, right? We know that it is serious. And recall about the classifications from class A, or from class 1, 2, 3, 4, 5. Remember about the severity and the mildness of the disorder in the earlier, or in the class 1 and 2. So it's not really that fatal initially, right? So that is not quite true. So we are eliminating letter A, expecting the disease to be fatal eventually. But with the word eventually, it's very vague. We don't know for sure when this exactly gonna happen. The respiratory muscles we know will be involved in the myasthenia gravis, and many patients will be able to manage their condition even at home while they are treating themselves at home. And it will really require diligent, lifelong treatment. But the option itself, it's kind of like overly pessimistic. It doesn't reflect the modern advances in the medical treatment. Does not reflect the advances in medical treatment. So it's like, yeah, they're just like sounding so hopeless, right? This time, expecting the disease to be fatal eventually. It's pessimistic statement. Removing that one. Let's have letter B, believing the disease will be cured. Did we say something about the cure for the MG? It is incurable, okay? Incurable, will be cured is wrong. The disease is incurable. The treatments that we're offering to the patients are basically intended to manage the symptoms. So only the treatments are intended to manage the symptoms. That's it. We're only improving the quality of life, but it doesn't really cure. Let's take a look on letter C, managing symptoms and maintaining a healthy lifestyle. Sounds kind of optimistic, right? Very good. That is the correct answer. It is reflecting a much more realistic understanding, much more realistic. And it actually acknowledges that the disease process itself is a chronic condition. Yeah, it is chronic. It is also progressive, but we can mitigate the manifestations. There's going to be lifestyle adjustments that we can do. Lifestyle modifications can be effective in this patient. So this is the correct answer. If you're answering letter D, anticipating occasional muscle weakness despite treatment, what does that mean? Despite treatment? Ooh, that doesn't sound good at all. The patient is not responding to that particular therapy. So basically, this patient is the patient would really require the other alternatives, right? We have the different modalities of treatments, the alternatives. So if they are really saying anticipating occasional muscle weakness, no, that's not quite true. There are alternatives to the treatment. As we know, we have the anticholinesterase, we have the immunosuppressants, and we have a variety of those immunosuppressants as well. Lifestyle changes, modifications. That is not true. This is incorrect. So we have our answer, which is letter C. Okay, so when you are being tested with this type of question, you really need to think about the disease management, especially for the chronic disorders. And the best answer about letter C here is that it is reflecting a much more balanced understanding that will combine the realistic expectations plus the proactive approach in treating the patient. Okay? Now let's have number 4 this time. An hour after administering pyridostigmine to a post-thymomectomy myasthenia gravis patient, they report nausea and severe cramps. What should the nurse do first? Is it A, listen to bowel sounds, B, contact the healthcare provider, C, give an antiemetic, D, administer prednisone? An hour after administering pyridostigmine to a post-thymomectomy myasthenia gravis patient, they report nausea and severe cramps. What should the nurse do first? What is this? Take note about the statement, the root statement here. After administering pyridostigmine post-thymomectomy, report nausea, severe cramps. What should the nurse do first? This is a life-threatening scenario, guys. Remember about the crisis. this will require immediate action. So what would be that? Are you just going to treat the patient symptomatically this time, or are you going to really have to do much for this patient? Removal of the thymus gland, because it's known to cause the production of the antibodies. But here, the nurse is giving the pyridostigmine. Come on, wake up, people. Wake up. Wake up, wake up. Remember about the crisis. All right, let's start to eliminate one thing here. Letter D, administer prednisone. Prednisone is what? The corticosteroid, right? It is one of the treatments in the myasthenia. It is an immunosuppressant. But do you think the steroid prednisone, this is oral, do you think that this can address the issue of the severe cramps? And there's more than the severe cramps here, guys, and the nausea. There's more to that. It will not be sufficient. It will not address the immediate need to counteract the effect of the pyridostigmine. We are in a cholinergic crisis. Please take note. These are signs of cholinergic crisis: severe cramps, nausea. The prednisone will not address that one. We need to do what? Call the medical provider. Contact the healthcare provider. Do not delay. Do not give the antiemetic because it is expected that they're going to be emesis. You're only treating the patient's symptom, but we need to contact the medical provider. This is critical. Guys, cholinergic crisis is critical. We need to make sure that the physician is notified first, because the symptoms are only the superficial evidences about the cholinergic crisis. And the pyridostigmine can lead to the accumulation of the acetylcholine, overstimulation of the muscles. Do you remember about those signs in cholinergic crisis? Yeah, it will require more nursing action. So we need to notify the medical provider so we can get those needed orders. We need to get those necessary medication orders so we can intervene right away. Okay? So when you're going to call the medical provider, this will constitute getting the atropine to counteract the effect of the pyridostigmine. It will avert the crisis. So if you are answering, or if you had answered, listen to the bowel sounds, I know it's a good intervention, you're listening, but you need to keep an eye that your patient is already in a crisis. You need to know really what those crisis signs and symptoms are. You just gave the pyridostigmine, and on a patient with post-thymomectomy, you don't need more assessment finding here. You need to call the medical provider. It is life-threatening. Listening to the bowel sounds will take less priority this time. Okay, you are delaying the treatment. All right, delays treatment, even though it's a good intervention, but will it address the crisis? No, it will not. Our patient requires immediate attention. I repeat, removing that, removing this, removing antiemetic. Antiemetic medication can only address the symptom, like I've said earlier, but will not address the underlying cause. We are in a crisis, cholinergic crisis. All right? This is also wrong. Contact the healthcare provider right away. Let's talk about number 5. Which assessment is crucial for a nurse to perform on a myasthenia gravis patient? Is it A, pupil size, B, grip strength, C, breathing effort, D, consciousness level? Which assessment is crucial for a nurse to perform on a myasthenia gravis patient? Forgot to take my medication today, guys. All right, which assessment is crucial for a nurse to perform on a myasthenia gravis patient? Is it pupil size, grip strength, or is it breathing effort, or D, consciousness? Let's start to eliminate some things here. Let's take a look on letter D, consciousness level. We know that consciousness level is very important to assess the overall neurological status. Important. But is it the most critical assessment in myasthenia gravis? Especially that we're going to be worried about the breathing. Not as important. We're going to select letter C, breathing effort. We're going to be worried about the airway patency, the breathing, and the circulation. So the respiratory effort, the breathing effort is the most crucial assessment because of the respiratory muscle weakness. This is important, but less critical. Okay. What about letter A, pupil size? Remember that there's also a change in the pupillary size, right? In myasthenia gravis. Yeah, but it's not as critical compared to the breathing effort. It is not a priority assessment. Okay, what about the grip strength? Yeah, it can also capture weakness in the muscles, right? It is also important. It is a common manifestation in MG, but it is not as critical as monitoring the breathing effort. Not as critical as C. Focus onto the airway, breathing, circulation, guys. That is paramount in assessing the patient with myasthenia gravis. So what we're focusing here, the question is asking for a crucial assessment. We are going to find that assessment that can pose life-threatening complications like respiratory failure. This is huge. All right. All right, before I'm going to proceed with the next item, again, I'm inviting everyone to enroll to our NCLEX program at www.stancoastnclexcoaching.com. Please click the link below so you will know more about the pricing and of the services that we are offering as well. Please do so. Okay, we have upgraded our library of our on-demand videos and also the animated videos for you to watch. All right, thank you guys. Now let's talk about number 6. Which patient should the nurse assess first after a shift change? Is it A, myasthenia gravis patient with increased muscle weakness, or B, patient with a bilateral headache, or C, patient due for phenytoin, and D, Parkinson's patient with new arm rigidity? So take your pick. You have 4 patients to deal with. So which of the 4 patients are you going to assess first after the change of shift? Oh boy. Which one? Is it A, is it B, or C, or D? Okay, let's try to eliminate one here. Letter D, Parkinson's patient with new arm rigidity. Okay. Parkinson's patient with new arm rigidity. Okay. Yeah, it will require assessment. That's true. Requires assessment and possibly medications, right? Yeah, they might require that. But is this urgent to, as compared to the correct answer that we'll be going through, is this urgent? No, it isn't. This situation in letter D can wait. It's not as urgent to that choice. Let's take a look into letter C. Patient due for phenytoin. Due for phenytoin. Is this life-threatening? We know that phenytoin is an anticonvulsant, right? It will be important in the control of the seizure. But do you think that this is really urgent for this patient? I don't think so. If the scenario stated about active tonic-clonic seizure, probably I would select letter C. But a patient due for phenytoin, which is basically a regular routine medication to control the seizure episode, that doesn't call for an immediate assessment. Due for phenytoin. Again, phenytoin is an anticonvulsant that will control the seizure. It doesn't really need to require, or it doesn't require you to administer right away the medication. No, it is not as urgent because the patient here is much more stable this time. Again, if the situation is different, if it said active seizure, then I would see this patient first, but it's not saying that. So we are eliminating. What about letter A? Myasthenia gravis patient with increased muscle weakness. Increased muscle weakness. That's an ominous sign, guys. This is an ominous sign that our patient can potentially develop into a myasthenic crisis. Potentially develop to a myasthenic crisis. All right. Crisis. Increased muscle weakness. Pay attention to that clue. Okay. Our patient is in a medical situation. It's a medical emergency that we need to address right away. We need to address this one first. It can lead to respiratory failure because it can involve the respiratory muscle. So we need to recognize this patient first so we can manage them as early as we can to prevent the complications. If you had answered letter B, patient with a bilateral headache. Bilateral headache, really? The presentation is already vague. It's not even giving us a number. How bad is the headache? There's no quality. Is it piercing type of headache? Is it a band type of headache? Headaches can be managed, but with the vagueness of the information, it's not considered urgent. They are less urgent compared to a patient that has increased muscle weakness who is going to potentially develop the crisis, myasthenia crisis. Righty. We are keeping letter A. Let's talk about number 7. If you have seen this patient with a myasthenia gravis, man, you would be like, oh my God, they're going to have that increased lacrimation. They just look so sad. Their effort of breathing is just way too bad. Why are you always erase my wrong answers? You hear better than there. Okay. Please don't erase your answers, stated by AJ. Right? Yeah, don't be ashamed. Yeah, keep your answers, guys. Yeah, don't be ashamed. I'm okay actually. If you're gonna commit wrong answers this time, I really don't mind. We need to learn here. Okay, that's true. All right, let's go to the next question, number 7. The nurse is administering 0800 medications, 800 a.m. or 8 a.m. rather. The nurse is administering 8 a.m. medications on medical floor. Which medication should the nurse administer first? Is it A, prostigmine, a cholinesterase inhibitor, to a client diagnosed with myasthenia gravis? Or is it B, methylprednisolone, a glucocorticoid, to a client diagnosed with lupus erythematosus? Or is it C, morphine, a narcotic analgesic, to a client diagnosed with Guillain-Barré syndrome? Or D, etanercept, a biological response modifier, to a client with rheumatoid arthritis? You are the nurse preparing for the meds of your patient for the 8 o'clock schedule. So which of the meds that you should prioritize? All right, while you're looking for the answer, I'll start answering this time. Mary is quick, answering letter A. Good. Let's have letter A this time. Etanercept, biological modifier, for a patient with rheumatoid arthritis. Yeah, it is actually an anti-inflammatory. Okay, this is an anti-inflammatory. Okay, that is indicated for the RA, or the rheumatoid arthritis. It is one of the treatments. But it doesn't really require strict timing. Does not require strict timing. So, for example, 8 o'clock is the schedule, right? You can give the medication probably 8:30. Within 30 minutes, within the time frame, that is acceptable. A slight delay in the administration of the etanercept doesn't really cause immediate risk. Slight delay is not going to be, slight delay, 30 minutes, will not be as crucial. It will not really pose immediate risk to the patient. No immediate risk if delayed with that given amount of time, 30 minutes. Not the first patient to medicate. Let's take a look in letter C, morphine, narcotic analgesic, to a patient with Guillain-Barré. What do you think about this one? We know that the patient with a Guillain-Barré can also require pain relief, right? But the timing of the administration of the morphine is not as critical compared to the best answer that we will be selecting this time. We know that we should be addressing the pain, but a slight delay of the pain medication administration is not life-threatening. Same reason, slight delay of administration doesn't pose life-threatening risk. Not life-threatening. Whoops. Oh boy. Not life-threatening. Okay, let's take a look onto letter A. Prostigmine, a cholinesterase inhibitor, to a client diagnosed with myasthenia gravis. What do you think about that drug? Do you think this patient should be prioritized for the 8 o'clock medication rounds? It is to be given promptly. There is a requirement. Prompt administration is required for the anticholinesterase. Yeah. Because the reason for that is we want to make sure that the drug level of the anticholinesterase will be maintained to prevent the muscle weakness. Maintains drug levels, okay, or adequate drug levels. This can prevent the occurrence of respiratory distress. It can prevent difficulty swallowing. It can also prevent the muscle weakness. That's why this is going to be our answer. Methylprednisolone, a glucocorticoid to a client diagnosed with lupus. Is there an urgency in this patient with a lupus? No. We are going to treat them accordingly, but it's not going to be, the timing here is not going to require a much more precise schedule. If it's scheduled at 8, yeah, we can give it at 8:30, 8:45. It doesn't really have a what do you call this? It doesn't have a huge impact as to the timing, okay? Compared to the anticholinesterase drug. It has to be maintained in that particular level to prevent subtherapeutic medication level. Our correct answer is letter A. Let's move forward with number 8. The nurse is administering medications to the clients on a medical unit. Which medication would the nurse question administering? Is it A, atropine, an antimuscarinic to a client with myasthenia gravis? B, chloroquine, an antimalarial to a client with a butterfly rash? C, prednisone, a corticosteroid to a client with polymyalgia rheumatica? And letter D, mestinone, a cholinesterase inhibitor to a client in a cholinergic crisis. What do you think, guys? What is your answer for this test question? The nurse is administering medications to the client on a medical unit. Which medication would the nurse question administering? Is it A, atropine, B, chloroquine, C, prednisone, D, mestinone? And of course, there's corresponding patient scenarios right there. Okay, be careful, guys. Be careful. Take priority in your answers this time. Prioritize your answer. Which one would be? Which of those patients? Are you sure? Okay. All right, let's start to eliminate here. I'm going to try letter C this time. Letter C. What is in letter C? Prednisone, a corticosteroid to a client with polymyalgia rheumatica. Yeah, this is a common prescription to this patient because of the inflammation, and this will also control the pain in this condition. This is appropriate or expected because the prednisone has anti-inflammatory effect. We are looking for that treatment that is inappropriate, reduces pain. So letter C is safe. We're going to remove that one. Let's take a look into letter B. Chloroquine, an anti-malarial to a client with butterfly rash. Chloroquine, it is an anti-malarial medication that is going to treat the lupus erythematosus. Okay? This is appropriate or expected treatment. So we're not going to pick this one up because we are questioning that medication. We are not going to question. This is good treatment. Now let's take a look onto the letter D. Mestinon, a cholinesterase inhibitor to a client in cholinergic crisis. Are you going to add more anticholinesterase in a patient that is already having the cholinergic crisis? Remember, guys, that when we have a cholinergic crisis, this is a result of excess anticholinesterase medication. Remember about that. Cholinergic crisis. This is caused by what? Caused by excessive anticholinesterase. Don't forget that. Anticholinesterase or cholinesterase inhibitor, those are the same. All right? Cholinesterase inhibitor or anticholinesterase, those are synonymous. We should not be giving any of that anticholinesterase medication on a patient that is already in cholinergic crisis, because the cholinergic crisis is caused by the inhibitor itself. So don't give any more Mestinon. No more. You should be dealing this patient. Okay? If you had answered, so this is the correct answer because this is what we are questioning. So that is the answer. If you answered letter A, atropine, an antimuscarinic to a client with myasthenia gravis, it's somewhat vague, but as we know that in a patient with a myasthenia gravis that will have the myasthenia crisis, our atropine will be used to what? It can be used to counteract the effect or counteract the effects of the cholinesterase inhibitors. Okay, so this is actually expected, but not letter D. Okay, that is the cholinesterase inhibitor, anticholinesterase, should not be given in this patient in a cholinergic crisis. No way. All righty. I hope that you're learning from this, guys. I hope so. Let's tackle number 9. The female client diagnosed with myasthenia gravis reports that the anticholinesterase medication makes her nauseated. Which information should the nurse teach the client? Is it A, decrease the dose of the medication? B, hold the medication and notify the healthcare provider? Or is it C, take the medication with milk or crackers? D, take an over-the-counter OTC proton pump inhibitor. The question stated, the female client diagnosed with myasthenia gravis reports that the anticholinesterase medication makes her nauseated. Which information should the nurse teach the client? Is it A, decrease the dose of the medication? B, hold the medication and notify the healthcare provider? C, take the medication with milk or crackers? D, take an over-the-counter OTC PPI. Let me try eliminating the distractors this time. Letter D, take an over-the-counter OTC proton pump inhibitor. So our patient is taking anticholinesterase, but she stated that it makes her nauseous or nauseated. So which information should the nurse teach the client? Okay. Well, as we know that the PPI, the proton pump inhibitors, they can reduce the stomach acid, right? Yeah, they're effective reducing stomach acid. They're going to be helpful in treating GERD as well. Gastroesophageal reflux disease. It is indicated for that. But will it be indicated for the nausea? Not indicated for nausea. Nope. It will not treat the nausea of our patient. Let's take a look into letter B. Hold the medication and notify the healthcare provider. Hold the medication and notify the healthcare provider. What do you think? It's not specific when the notification is occurring. Not specific. So, again, remember about the adherence, the schedule. Schedule of anticholinesterase. Remember about the time frame. We need to stick with the time frame. If it is really scheduled at 8, 8:05, 8:10, that's fine. But if we are holding the medication without a specific time frame, our patient can develop the myasthenic crisis. This is unsafe. I know the act of holding and notifying, it looks good, right? But considering about the timing, the schedule of the medication, it has to be maintained. The drug level of the medication should be maintained with the proper time intervals. We don't want to disrupt the schedule. So holding can actually harm the patient this time. We know that the patient is nauseated, but will the holding warrant? Is this really the best intervention to hold it? No. What we know of that can decrease the nausea of a patient is letter C. Take the medication with milk or crackers. That is our best bet this time. Yeah, it can decrease the mild gastrointestinal side effects. Okay, that is a correct answer. It will mitigate the nausea. Alrighty. And also the food that will be taken can also decrease the irritation in the stomach. Yeah, that's true. A nurse cannot decrease the dose. We always have to notify the medical provider. But the word here, holding, which is not really specific as part of the process, holding the medication, there's no time frame. And remember about the strict scheduling of the anticholinesterase. We don't want to delay the treatment. So the holding, if probably they're just going to hold it for the meantime and maybe make that call within 5 minutes, probably that would be it, but it's not clear. It's a vague statement about holding the medication. We did not have a specific 5 minutes, 10 minutes, no. So that is going to be unsafe practice for our patient taking anticholinesterase. If we are going to answer letter A, decrease the dose of the medication, we cannot do that. It requires the decision of the medical provider. Requires the medical provider order. Yeah, that's true. The milk took me off. If it was only crackers, I would have taken that option. Oh, okay. Gotcha. Yeah, but most often the milk will actually diminish the nausea. And it's not known to really contraindicate or interact with the medication itself. So our best bet here is letter C. Now let's move forward with number 10. The nurse administered idrophonium to a client diagnosed with rule-out myasthenia gravis. Which response by the client indicates the client has MG, myasthenia gravis? Is it A, the client loses the ability to breathe without mechanical support? B, the client's strength improves briefly without signs of fasciculations? C, the client cannot gaze at the ceiling for 2 minutes without fatigue? D, the client's paroxysmal atrial tachycardia converts to normal sinus rhythm. The nurse administered idrophonium to a client diagnosed with rule-out myasthenia gravis. Which response by the client indicates the client has MG? A, the client loses the ability to breathe without mechanical support. B, the client's strength improves briefly without signs of fasciculations. C, the client cannot gaze at the ceiling for 2 minutes without fatigue. And D, the client's paroxysmal atrial tachycardia converts to normal sinus rhythm. Guys, please use the elimination process. Think as much as you can. Eliminate those distractors. All right, I'm going to try to eliminate one thing here. Let me try letter D. The client's paroxysmal atrial tachycardia converts to normal sinus rhythm. So let's go back to the question though. Which response by the client indicates the client has MG? All right. We are administering the idrophonium, the tensilon test. I've emphasized this already earlier. Diagnosed to a client diagnosed with rule-out myasthenia gravis. Letter D. What is in letter D? Well, when it's stating conversion, the client's paroxysmal atrial tachycardia to normal sinus rhythm, there's no connection here. Unrelated to the use of tensilon test. There is no relationship. There's no correlation between the two. Okay? It doesn't influence the cardiac rhythm issue. Does not influence cardiac rhythm. Eliminating this one. What about letter C? The client cannot gaze at the ceiling for 2 minutes without fatigue. The client cannot gaze at the ceiling for 2 minutes without fatigue. Remember that the ability to gaze at the ceiling for 2 minutes without fatigue is a non-pharmacologic test. It is not. Again, the ability to gaze at the ceiling for 2 minutes without fatigue is non-pharmacologic testing and does not directly relate to the administration of idrophonium. It doesn't. Okay? So the test actually will assess the sustained muscle contraction, but not really provide specific information about the this gaze right here. The client's ability to gaze, or the client cannot gaze at the ceiling. It is again a non-pharmacologic testing. Okay. Let's take a look on letter A. The client loses the ability to breathe without mechanical support. Sounds good to be true, right? Yeah. Letter A. What do you think about letter A? Client loses ability to breathe without mechanical support. Well, this thing basically means that the patient's loss of the ability to breathe and needing a mechanical ventilator or support would not indicate a cholinergic crisis or not myasthenia gravis. Again, the loss of the ability to breathe and needing mechanical support would indicate more of a cholinergic crisis, not myasthenia gravis. Okay, and this would occur more when there is excessive acetylcholine due to the overmedication of the anticholinesterase. But the diagnostic finding for this is used rather to diagnose the MG. Okay, it is not going to what? It is not to the indication really here. Let's say the client loses the ability to breathe without mechanical support. Again, this is only pertaining to the patient leading to a cholinergic crisis, not a myasthenia gravis. So let's take a look on letter B. The client's strength improves briefly. Remember about that brief improvement? That is the word right there, guys. Don't forget. When the patient receives the tensilon or the idrophonium, it can what? It can result to a brief improvement of their muscle strength. There will be some reduction in the twitching. That is the correct answer. Letter B. Brief strength improvement without signs of fasciculations. Okay? This will determine if the patient really has the myasthenia crisis or could be the cholinergic crisis. All right, moving forward. Number 11. A patient has symptoms that are characteristic of multiple sclerosis. Why is this here? I guess I got the wrong question. Let me skip that one. Let's have number 12 instead. The nurse is caring for a patient who has myasthenia gravis and is receiving pyridostigmine bromide or mestinone. Again, this is a patient caring for, patient who has MG and receiving the pyridostigmine or the mestinone. The nurse notes ptosis to both eyelids and observes the patient has difficulty swallowing. What action the nurse perform next? What action will the nurse perform next? Is it A, contact the provider to request for an order for atropine sulfate? Is it B, contact the provider to request an order for idrophonium chloride or the tensilon? Or is it C, report signs of cholinergic crisis to the provider? Or is it D, report signs of myasthenic crisis to the provider? Now, your case here is on an MG patient receiving pyridostigmine. So she is taking this drug, anticholinesterase. And now the patient has been noted to have ptosis, both eyelids, and there is now difficulty swallowing. So what are you going to do here? You gotta be on your toes this time to check if the patient is he on myasthenic crisis or is it a cholinergic crisis. Remember that the patient is taking pyridostigmine. Okay, let's try to eliminate something here. Let's have letter D this time. Letter D. Report signs of myasthenic crisis to the provider. What action will the nurse perform next? Are you supposed to report signs of myasthenic crisis to the provider? Are you sure that this is really myasthenic crisis without checking first? Remember that the patient is already taking the pyridostigmine. Are you going to tell the doctor right away, hey, this is myasthenic crisis? Well, the answer to that, letter D, it is wrong. You have not confirmed yet that this is myasthenic crisis. Not confirmed. as myasthenic crisis. So don't tell the doctor that you are really seeing the patient is on a crisis. What about letter C? Report signs of cholinergic crisis to the provider. Will that help? Cholinergic. Do you think that this is really a cholinergic crisis without confirmation? Yeah, this can also lead to inappropriate management if you're telling the doctor, hey doctor, I think my patient is having a cholinergic crisis right now. No, you need to confirm that first. So make sure before you initiate any treatment, you confirm it first. Okay? What do you want this time? Yeah. Report signs of cholinergic crisis. This is also not confirmed. Let's have letter B. Contact the provider to request an order for idrophonium tensilin test. What do you think about this procedure? Will this help the care plan, or will this really identify the problem? Remember that your patient is already taking pyridostigmine, and the patient is now developing ptosis, both eyelids. Remember that ptosis of both eyelids can be a sign of myasthenia, or it could be a sign of the cholinergic crisis. Same thing with the swallowing difficulty. It could be a sign that the patient is in a myasthenia crisis, or it could also be a sign that the patient is on a cholinergic crisis. We are not sure. So we don't have any other options. That is letter B. Contact the provider to request an order for idrophonium chloride tensilon test. And this is going to differentiate the two crises. All right. Crisis, rather. Yes. Okay. So this will identify if it's really a myasthenia crisis or the cholinergic crisis. And as we know that the patient is already presenting the ptosis, right? Drooping of the eyelids, difficulty swallowing. They are non-specific. So we don't know for sure if this is either. So again, we have to confirm that with the administration of the idrophonium testing. If you had answered letter A, contact the provider to request an order for atropine sulfate. Again, we need to confirm that before we treat the patient. It could be excess acetylcholine. So if you are going to administer the atropine sulfate without even confirming, this can also cause more issues to a patient. So again, the atropine sulfate is only done, it is only indicated. Atropine sulfate is what? It is only used for treating cholinergic crisis. That is the intention of the atropine sulfate. And again, in this situation, we are not quite sure because the patient is taking the pyridostigmine. All right, let's good. All right, I'm seeing letter D, so that's not too bad. Number 13, the nurse is caring for a patient who has myasthenia gravis and takes pyridostigmine, mestinon, 60 milligrams every 4 hours. Yeah, I totally remember this. Our patient that has this frequency, man, oh man, they can be very demanding because of the schedule. They don't want to miss out on their dose on that particular time. Every 4 hours, 60 milligrams. Yeah, you got to be on top of your game if you're busy with other patients this time. So the patient's last dose was 45 minutes prior. The nurse notes severe muscle weakness, excess salivation, fasciculation, facial muscles, pupil constriction. The nurse will perform which action? Is it A, assess the patient for signs of ptosis? Or is it B, notify the provider to discuss an order for IV immunoglobulin? Or is it C, obtain an order for atropine sulfate? Or D, request an order for an extra dose of pyridostigmine? So now it's easy compared to, I mean, the sequence of the events here. Remember that the previous scenario, that's total disregard that one. This one is on a patient that receives mestinone every 4 hours regularly. So this is your hint what kind of crisis this patient is having, right? The frequency of the medication is every 4 hours, 60 milligrams mestinone. And it said here the last dose was 45 minutes prior. But this time, the nurse notes muscle weakness, excess salivation, fasciculation of facial muscles, pupil constriction. What do you think, guys? Your patient has consistent schedule of the pyridostigmine. This is totally different from the previous scenario. Every 4 hours schedule. And then the patient has the signs of weakness. This is a sign of what? Cholinergic crisis. There's no need for you to do the tensilone test. If the patient is on the schedule every 4 hours, on top of the schedule, if the medication has been given continuously, consistently, there is no need to do the tensilone this time. This situation alone reflects that the patient is in a cholinergic crisis. This is over medication of the anticholinesterase. Okay, so this could possibly require a reduction in the dose, or let's say a reduction in the frequency of the medication. So we are going to obtain an order for atropine sulfate to control the cholinergic crisis. This is our antidote. That is the antidote for the cholinergic crisis. It will block the effects of the excess acetylcholine and the muscarinic receptors. If you had answered letter A, assess the patient for signs of ptosis. Remember that the eyelid drooping is a characteristic symptom of myasthenic crisis mostly. Yeah, not usually the cholinergic. So we are eliminating this one. What about letter B? Notify the provider to discuss an order for IVIG. Will the IVIG treat the cholinergic crisis? No. The treatment of choice this time in a cholinergic crisis is to administer the atropine sulfate. The IVIG only will modulate the immune system. So it doesn't really have an effect onto the crisis. We are marking that wrong. What about letter D? Request an order for an extra dose of pyridostigmine. Our patient is already in a cholinergic crisis. We don't want to give any more the pyridostigmine. Contraindicated. Guys, you only do the tensilone test if you are not sure, because the information in the chart was, or let's say the information in the scenario is not there completely. We don't have any other clear evidence. So that's the time that you need to confirm it in order to differentiate between the two crises. However, in this scenario, when your patient is already taking the mestinone regularly, we don't have to differentiate the crisis here. It is going to lean towards a cholinergic crisis, a possibility of over medication. Number 14. Are you still nauseous this time, guys? Talking about the mestinone and the prostigmine. Trying to Sharpen your brains today. Number 14. The nurse assumes care of a patient who has myasthenia gravis and notes that a dose of neostigmine due 1 hour prior was not given. The nurse will anticipate the patient to exhibit which symptoms? The nurse assumes care of a patient who has myasthenia gravis and notes that a dose of prostigmine due 1 hour prior was not given. A delayed medication. The nurse will anticipate the patient to exhibit which symptoms? Is it A, excessive salivation, B, muscle spasms, C, muscle weakness, D, respiratory paralysis? What do you think, guys? All right, let me eliminate respiratory paralysis. What do you think about that? An hour delay? Will that cause respiratory paralysis for this patient already? Well, paralysis of the respiratory function or respiratory muscles, this is severe, okay? And this is going to be found only in myasthenic crisis. We know that the missing, or let's say a delay in the prostigmine can contribute to the muscle weakness. But respiratory paralysis is not typically an immediate consequence of a single missed dose. Okay? Not a typical immediate complication to one missed dose. It isn't. But the respiratory paralysis can be a complication when there is severe myasthenia gravis exacerbation, not about missing a dose, eliminating that one. What about letter A, excessive salivation? Take note about the salivation. Did we mention about the salivation earlier regarding the cholinergic crisis? Yeah. This is a sign of cholinergic crisis. Over medication. This is what we term as sialuria, or sialuria. Excessive salivation. Again, this is caused by excessive cholinesterase inhibitor. Excessive anti-cholinesterase. Okay. We are eliminating that as well. Remember that our scenario is about prostigmine delay. What about letter B? Muscle spasm. What do you think about the muscle spasm? This can result in a cholinergic crisis because of the excessive acetylcholine. Excessive ACH. So we are neglecting this one. Muscle weakness is the correct answer. When there is a delay in the administration of the prostigmine, let's say 1 hour, this will result into the decreased acetylcholine levels, and which will eventually can result to inadequate neuromuscular transmission. The muscle weakness is the best answer. Decreased transmission. Are you still okay there? Pulse. Okay, that's number 14. It's already 12. Let me have the last test item here. During an hydrophonium test, what should the nurse do? Is it A, check muscle strength after 5 minutes. B, provide emotional support. C, prescribe atropine if weakness worsens. D, take a medical history. Again, the during an hydrophonium test, what should the nurse do? Is it check the muscle strength after 5 minutes? B, provide emotional support. C, give prescribed atropine if weakness worsens. D, take a medical history. Okay, remember about the duration, right? The duration of the medication will be around like 10 minutes. Okay. But when you are assessing your patient, it doesn't mean that you're only going to have to start after that certain time, or let's say 5 minutes. So eliminate those distractors, guys. Let me have letter D this time. Take a medical history. During an hydrophonium test, what should the nurse do? Are you going to do this instead? Take medical history. We know that taking the medical history is very crucial, especially when we are dealing with a neurological disorder, right? But we are going to shift our attention into focusing into the acute responses to the medication to distinguish either the cholinergic crisis or the myasthenia crisis. So this is not going to be applicable at this point. Okay? Not appropriate. Around this time, what we need to do is basically to monitor the patient for their immediate responses. Maybe they're gonna go into a crisis, or it could be something else. But medical history taking this time is not appropriate. It should be done prior. Okay. Now let's take a look onto letter C. Give prescribed atropine if weakness worsens. What do you think about that one? Give prescribed atropine if weakness worsens. Will that be appropriate nursing intervention? Okay, let me have a review real quick. The hydrophonium test is what? It is used to differentiate between the myasthenic crisis and the cholinergic crisis. And we want to make sure that atropine should be readily available if there is worsening of the weakness. That is required, guys. We need to have a prescribed atropine if weakness worsens. We know that the test itself can be short-acting, right? It has it is an anticholinesterase. It is an anticholinesterase that can improve the acetylcholine in the body, in the neuromuscular junction. And so if in case the patient will have an increase in the weakness after you give them the medication, if it is increasing, remember, if the weakness is increased, what does it mean? Remember that it is reflecting cholinergic crisis. If the muscle weakness increases. If this is myasthenic crisis, what are you going to expect? Myasthenic crisis. What are you going to see here is improvement of muscle strength. Okay? So take a look into the differences about the cholinergic crisis and the myasthenic crisis. So if you are selecting this one, give prescribed atropine if weakness worsens. That is the correct answer because it reflects that the patient has cholinergic crisis. If you had answered letter A, check the muscle strength after 5 minutes, the checking or the monitoring of our patient should not should not be done after 5 minutes. What you're going to do here instead is to continuously monitor the patient all throughout the duration, not just 5 minutes after. Okay? Wrong. It should be continuous monitoring of the muscle strength. So we are eliminating that one. Provide emotional support. Yeah, it's a good thing to have that as well, but it's not really the primary intervention around this time when you are trying to identify whether it's crisis, myasthenic crisis, or it's cholinergic crisis. That's not the goal of our treatment. Okay, so no other answer but letter C. Okay. All right, so I found that probably you're having a hard time with these test questions. It's very complex, especially with neuronursing. It's very complex. So I hope that you are learning as far as the different observations, the monitoring of our patient, and when we are testing them for the hydrophonium test. Make sure that you are able to distinguish between the two crises. That's very crucial, guys. You will not be able to administer the correct treatment if you are not able to identify the two. And I really recommend that you review this video or study more on the Myasthenia Gravis treatment in order for you to have a much more understanding. So I thank you for your participation today, and it's quite late already in North America. So you have a good evening or a great night. Get some sleep, and I'll see you again tomorrow. For those who are in Asia or Europe, let's have a better day today, I guess, and keep studying. And so I'll see you again at 9 p.m. tomorrow, Eastern Standard Time. You all take care, guys. Bye-bye.